We shall now go on to our next speaker, Dr. Ramakrishnan, who's a consultant neurology and the head of the Department of Neurology at KG Hospital, Coimbatore. And he's going to be talking on management of optic neuritis from the neurologist's point of view and an overview of the demyelinating disorders affecting the optic nerve. On to you, Dr. Ramakrishnan.
Hello, am I audible?
Yes.
Thank you, madam. Thank you, Dr. Murli and his team for giving me this opportunity to talk to all the ophthalmologists with optic neuritis, which will be probably bread and butter to ophthalmologists. So what I try to do is what is something new or what is the unusual things which we see as optic neuritis. When the time is up, please inform me, madam, because I might be going a little fast. Next slide, please. Optic neuritis, as we all know, it's an inflammatory disorder of the optic nerve, which could be due to demyelination. It could be due to inflammation, infectious or non-infectious causes. We all know that optic neuritis, the most common cause is multiple sclerosis, but it is as per the Western literature, whereas there are many studies which are from our part of the country and from the Asian population, where MS may not be the commonest one, and there are other causes also. And we all know with the discovery of these serological markers, it has revolutionized the treatment not only for optic neuritis, but also for other demyelinating disorders also. Next slide, please. This is, we all know that is for optic neuritis treatment trial. Most of our treatment is based on the optic neuritis treatment trial protocol. One thing we have to keep in mind is, in case of MS or idiopathic demyelinating optic neuritis, a delay in treatment doesn't have a bad outcome propensity. For example, there are, you might be knowing that studies say that whether you treat with high dose steroids, oral steroids or IV steroids, after years, the degree of outcome and the relapse rate is not significant between people who have received steroids and have not received any steroids. But in case of other conditions like go to the previous slide. Okay. Non-MS IDON, that is either aquaporin 4-based optic neuritis or MOG based optic neuritis, we have to be careful because delaying treatment, there will be a worsening of visual outcome or outcome may not be what up to our expectation. Next slide, please. Next slide. This is just a basic previous one. And basic outflow of what we do or what we think when somebody comes to us with suspected optic neuritis. We should look for red flags. That is somebody who has got a significant visual loss, or somebody who has got a limb weakness, or somebody who has got a previous similar episodes of the optic neuritis or limb weakness. These are the red flags we have to think. If it is a typical case, then we will have to do an MRI brain with orbits. If it confirms MS, then we have to treat as a MS along with disease modifying therapies here. So if it is the MS doesn't show features of MS, then we have to treat it as a clinically isolated syndrome. We have to give steroids and then nowadays followed up with disease modifying therapy and to follow. Whereas if somebody has got features of atypical optic neuritis, which I will be discussing in the subsequent slides, then we have to give steroids. If there is no improvement, we have to go for plasma exchange or IVIG, preferably plasma exchange at the earliest, because in case of NMO disorders, delaying treatment even by few days will have a negative impact on the visual outcome. So if it is a positive serology, NMOSD, we have to give immunotherapy. In case of MOG antibody disease, we have to give steroids. And generally what we do is we repeat the serology after 6 months and take it forward further. But it's a negative serology, then we have steroid, slow taper of steroids. And if these things doesn't come, it matches with our clinical profile, then we have to consider other investigations like looking for SLE, looking for sarcoidosis, looking for neurosyphilis, all those things. Next slide, please. What is typical optic neuritis? I think we all know, so I may not go much into it. Generally, these people have a subacute unilateral visual loss, which develops over hours to days with associated pain on eye movement. The optic disc swelling will be absent or there will be minimal optic disc swelling will be there. The optic disc hemorrhages or vitritis and subretinal fluid may not be there. This is in typical optic neuritis. If we have findings which are atypical to it, then we have to consider other causes. Next slide, please. So severity of visual loss usually reaches its peak within 2 weeks. So this we have to keep in mind. If somebody has got a progression of visual loss which worsens even after 2 weeks or even after 3 weeks, that means we have to think about our diagnosis. That means we are missing something, a missing link is there. We have to work on that. Spontaneous recovery and an outcome of mild to moderate visual loss is the rule. So if somebody has got an optic neuritis and if the visual loss is severe on recovery, that means it may not be a typical MS or idiopathic demyelinating optic neuritis. We have to look for other causes. Deviation. The next slide, please. So these are all the characteristics. This will be there in every book, so I'm not going much into it. Only thing is the visual acuity defects. It will be severe, whereas in case of both NMO and MOG, whereas it will be mild in case of MS. So mostly it's a female disorder in case of NMO. In MOG it's 57% and in MS 77%. These things will come in the subsequent slides. Next slide, please. So what are all the atypical features? First thing we have to know is we have to consider pain. So pain, why patients with optic neuritis have pain is due to involvement of the intraorbital portion of the optic nerve. So we know that, for example, anterior ischemic optic neuropathy, they won't have pain. Similarly, since this NMO disorder, there is involvement of the intracranial part of optic nerve, that is the retro optic chiasm and the intracranial part of the optic nerve. Pain will not be that much common, or pain is less common. So when somebody has got pain which is provoked or exacerbated by eye movement, it indicates intraorbital involvement, which is more likely in MS. And subsequent next common is MOG. When there is painless, then we know other causes. But one thing we have to keep in is NMO related optic neuritis, the pain is less common. Next slide, please. So when somebody bilateral simultaneous onset, this we all know. When somebody develops a bilateral simultaneous onset or sequential onset optic neuritis, then probably MS or IDU, that is idiopathic demyelinating optic neuritis, is less common. Usually it occurs in case of MOG antibody, MOG optic neuritis. You can see it is 50 to 84%. In aquaporin 4 related optic neuritis, 20 to 25%, or it could be due to post-infective or post-vaccination optic neuritis. So this thing we have to keep in mind. If there is bilateral involvement, either sequential or spontaneous, so the other one, atypical ones, are more likely. Next slide, please. Moderate to severe optic disc swelling. So in case of MS, the optic disc swelling will be often mild. So if you have a patient who have got severe optic disc swelling or the presence of peripapillary hemorrhages, this is more in favor of MOG optic neuritis. It is rare in MS. It is uncommon in aquaporin 4 related optic neuritis, whereas it's common in MOG. So if this edema is more, MOG appears more likely. So this is we have to keep in one, the presence of pain and the bilateral involvement and degree of optic disc swelling. Next slide, please. So this we all know, very young or old patient. Generally, MOG is more common in children. So initially, we saw patients with MOG disease mostly in children. Nowadays, we are seeing in elderly also, but it's more common in children. MS usually occurs in the 20 to 40 years of age. Aquaporin is little later, that is 4th to 5th decade. MOG and aquaporin are seen among all age groups, but this is the general trend. In children, we think more in favor of MOG. Little elderly, we think more in favor of NMO, whereas MS usually occurs between 20 to 40 years of age. So this depends on the age of the patient also. Next slide, please. This is what I was mentioning. This is a study, I think it's published from Shankar Netralaya. They have done analyzed cases of 203 cases of optic neuritis in India, where we know that prevalence of MS is lower when compared to Western world. In their series, the most common one was MOG optic neuritis, seen in 28% of population, followed by aquaporin 4, which is seen in 9.9%, and MS in 5.9%. So most common one in the series was 28%, which is seen in MOG antibody. Remainder were either serologically negative with no evidence of MS. Next slide, please. Next slide. So this is the article. I think it has been published in 2022, in the January, in the Journal of Ophthalmology. This is clinical profile, imaging features, and short-term visual outcomes of Indian optic neuritis patients with and without seromarkers for MOG antibody and neuromyelitis optica. Next slide, please. The deterioration after steroids. For example, we give steroids and stop the steroids. If there is deterioration of vision after stopping steroid, most common thing which will come to our mind is sarcoidosis. Because sarcoidosis is one condition where they will respond very well to steroids. And if there is worsening after stopping steroids, sarcoidosis is one which we have to keep in mind. Generally, deterioration of vision will not occur after stopping steroid, but it can occur if we stop the steroids very early, or in case of MOG antibody disease, where they will be very much sensitive to steroid. We can have worsening after stopping steroids. So where and all we can have worsening is most likely with granulomatous disorders like sarcoidosis, as post MOG antibody disease, crayon. Here and all we can have worsening with after stopping steroids. Next slide, please. Initial severity of visual loss. So generally, severity of visual loss, based on that, we may not be able to differentiate between typical and atypical ones. But generally, in case of MOG antibody disease and in NMO, the degree of visual loss is much severe when compared to related to MS-related optic neuritis. But it is not common. In different studies, the percentage of people having severity of visual loss varies. But generally, if it is more severe, then it is less likely to be MS-related disease. Next slide, please. Antibody testing. Do we need to do antibody testing in all the patients? Then, as we all know, if we do the test, it takes some time for the test to come, for the test to become available for us. So if you have clinically, we have all the features. If your MRI is falling into the category which we know, then probably we need to do antibody testing in patients whom we think it is typically fits in with MS-related disease. But if it doesn't follow the pattern of typical optic neuritis, then we need to do antibody test. While doing test, what we have to keep in mind is we have to do it labs where they use cell-based assays. Whereas there are many labs which should do tests like with enzyme immunoassay or ELISA test, where the reliability of the test is less. So we have to do in lab where they do cell-based assays. And for example, in case of MOG or NMO, we need not do CSF assay. Since the MOG which is seen in CSF is not due to intrathecal production of antibodies. So it is enough if we do in serum alone, no need to do CSF assay. So these are the two things which we have to keep in mind. Next slide, please. Neuroimaging is one which has really helped us in making early diagnosis and starting appropriate treatment. Based on distribution of lesions in the brain and the optic nerve, we will be able to differentiate typical from atypical cases. Next slide, please. Generally, it is more than 17 millimeter involvement of optic nerve. We call it as longitudinally extensive involvement. General tendency. Next slide, please. Okay. Okay, then it will come in the subsequent slide. Generally, MOG antibody disease has a tendency to involve anterior part of the optic nerve, whereas NMO disorder tends to have involvement of the posterior part of the optic nerve, the intracranial portion, and the optic chiasm. But that is one thing we have to keep in mind. And asymptomatic brain lesions will be more common in MS. That is, patient comes with optic neuritis. If we see many lesions in the brain, that generally unlikely to be MOG antibody disease, because with time and MOG antibody disease, these lesions will disappear. They won't persist. So these two things we have to keep in mind. Next slide, please. In aquaporin 4 disease, that is NMO, they have typical sites where the concentration of aquaporin 4 antibodies are high. Aquaporin 4 antigens are high. That is, either in the area postrema or floor of fourth ventricle or hypothalamus. So if you are seeing lesions in this area, then it is more likely to be aquaporin 4 related disorder. Next slide. Similarly, if you have longitudinally extending lesions in the cord, it's more in favor of either aquaporin 4 or MOG antibody disease. Generally, if there is involvement of conus medullaris, it is more likely with MOG antibody disease. Whereas involvement of the upper part of the cord, that is cervicomedullary junction, it favors aquaporin 4 antibody disease. I think that should be enough for at the point of time. Next slide, please.
You have to
So,
conclude, Dr. Ramakrishnan.
Oh, okay, madam. Next slide. That means you go next slide. Next slide. So these are all the MRI pictures. No, previous slide. Previous slide. Okay. Okay. This MI eye finding alone you can concentrate. So NMO, it has got involvement in posterior part of the optic nerve and chiasm. MOG has got a anterior, whereas in MS it will be short segment. So next slide. Next slide. Next. 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 This is one. It's a little busy slide. Before previous slide. So if somebody present with optic neuritis, what we are supposed to do? We should see whether it's a typical optic neuritis or atypical optic neuritis. If it is typical optic neuritis, we can start them on steroids as per ONTT protocol. If it is an atypical one, then we have to start. Next slide. We have to consider plasma exchange early. We should not wait for the next slide. We should not wait for the steroid effect to occur. That is, in case of aquaporin 4 antibody disease, if we delay by 7 days, the visual acuity tends to be poor. Next slide, please. So plasma exchange should not be regarded as a rescue therapy. It should be considered in the first itself. Next slide. There is no need for long-term immunotherapy in case of MOG antibody disease, unless in stressful situations like steroid dependency, if it is relapsing course, or if it is significant disability, or if it is persistent antibody positivity. Next slide. I think that is the end of the presentation. Thank you, madam. I would like to answer if there are any questions.
Yes, that was a very nice talk, Dr. Ramakrishnan. Was very interesting. When would you decide to initiate a disease-modifying treatment in a clinically isolated syndrome?
Madam, when initially, for example, previously, when somebody has got a clinically isolated syndrome, the approach or recommendation was to wait and to start disease-modifying treatment if there is a relapse. But these things have changed because nowadays the concept is we have to treat early, and if at all, we have to treat with a good efficacy drug. For even in the case of a clinically isolated syndrome, if you have got MRI lesions which are typical of MS, it is better to start disease-modifying treatment. We need not wait for the second attack to occur. So we have to start immediately. Only in radiologically isolated syndrome, that means you do MRI something else for headache or vertigo, something else, and if you find a lesion which is typical of MS, we can wait. Whereas in case of clinically isolated syndrome, the present concept is to start them on medications.
Yes. Dr. Murli?
Yeah, sir, in patients with optic neuritis, do you routinely recommend spinal screening, or you do spinal screening only when there are symptoms?
We have to do screening in all the patients with optic neuritis. Actually, in centers where they treat the demyelinating disorder, they have got a demyelination protocol. They've got a demyelination protocol where they will do the brain, where they will do the spine, they will do the orbits also. So unless we do spine, we won't be able to pick up spinal lesions. For example, in case of MS, they might be having previous spinal cord lesions, which we may not be able to pick up. If that lesion is there, it will help us to confirm the diagnosis or make the diagnosis. We have to do.
But sometimes it is in the initial presentation, there may not be any spinal cord lesions. As the disease progresses a couple of years later, those lesions may.
Yes, madam, because we need a baseline MRI, at least to know initially the lesions were not there. Now, if somebody develops a new lesion, that means it is a relapse. At least it will help us to modify the treatment. For example, somebody is on interferon, and after 1 year, he develops a spinal cord lesion. That means the interferon is not working. We have to step up the disease-modifying drug, no, madam. We need a baseline MRI, definitely.
But would that amount to the wrong diagnosis that because they did not find any lesions, They may not label it as an MS, and then some years later, then you repeat an MRI and you now find lesions, and now you are ready to label the patient with an MRI as MS.
Yes, madam. For example, if somebody has got an optic neuritis, if you do an MRI brain and then if you do an MRI spine, if both are normal, that means this patient, the chance of developing MS in the subsequent 5 years is less. But if you find lesions either in the brain or in the spinal cord, the chances of that patient developing MS in the next 5 years is high. So we will treat them on disease modifying therapy. If we don't find lesions, that means we may not be able to make the diagnosis, no, madam. At that time, starting disease modifying therapy will be probably more risky.
Yes, yes.
Is there any regional difference in the presentation in the different parts of our country?
Yes, definitely, madam. Because when we attend conferences, many of the times the lesion seems to be extensive and multiple, especially from the northern part of India. Whereas in case of our side, from the southern part, we don't see, in case of emoji, such an extensive lesion, such a long-term extensive lesion, we generally do not see. I feel it is much more florid, much more varied. NMO, so from Nimran, they presented a case series where different manifestations and different lesions were there. Such an extent we are not seeing in the southern part.
Okay.
Thank you.
Thank you.